So welcome everyone. Glad to see everybody here today. I am very, very happy to be able to introduce our speaker for today, Chris Fruitrich. And am I saying your last name correctly, Chris?
Yeah, it's really a lot easier than it looks. It's fruit like an apple and rich like Bill Gates. That's how I always say it. So
Excellent. Thank you. Chris is here with us from End of Life Washington, and he's going to be talking about a few different topics today. He's also agreed to take questions. So as I mentioned earlier, but for anyone who missed it, if you do have a question, feel free to go ahead and just raise your hand up.
one of the things is getting an early start in talking about the end of your life. I can't stress enough how important that is on a number of levels. But just let me say that I think as a nation, we do as bad a job as anyone internationally of talking to our families about how we might want to die. Of course, we can't ever anticipate when, under most circumstances, although that's something we'll cover in a few minutes. And just get the notion out there to your family. And this conversation doesn't have to be when you're 6 months or less away from what appears to be your death. This is any time. I think it's really critical that everyone knows what we would like to happen, and that happens through your will, through your desires about how your remains are taken care of, what quality of life means to you. And the important thing about this is that conversation can start with a child or a grandchild who is 12 or 15, and it can continue for years, and it continues to change because I'm 73, I still feel pretty good. I don't feel like it's time for me to check out, but I want to make sure that my kids know, my wife, my kids, my friends, what's going to happen. And I've even written out a little addendum or codicil to my will explaining that I want to be cremated, and then I have instructions, careful instructions for one of my friends to take a small amount of my ashes and take them over to the home course, golf course in DuPont, and sprinkle them into the sand trap in front of the 16th green where I got my one and only hole in one after 50 years of playing golf. So those are the kinds of things that if you don't get it out there, it's not going to happen. And there are many, many more things, and specifically as it relates to End of Life Washington and death with dignity, what happens when your quality of life begins to decline to the place where you can no longer do the things you enjoy, you can no longer see the people that you love. Those are things that need to be on the table. Now, can I have a quick show of hands? How many of you have an advanced medical directive that tells people what to do in the event that you're not able? Cool. Okay. Let's have a second show of hands. How many of you have that stored someplace where your medical power of attorney or your family could find it if you went out and keeled over tomorrow? There are some slow raisers and some no raisers, and that's what I've run into a lot, is that people get these things done, and some go to a lawyer. You can find one on our website. You can find them elsewhere on the internet, and they get all filled out, and you're absolutely certain that everybody knows, and then they go in a file cabinet or the bottom of your desk drawer or in a place where you can certainly find it easily. But when you're comatose on a gurney, not going to do you any good. So it's really important that this conversation gets started early on. I may be preaching to the choir here, but it needs to be said. From here, does anybody have any questions about that they would like to toss out there? Reservations, other thoughts, things like that. I do want to say that as a resource for not only death with dignity, but as a resource for a lot of end-of-life decision-making. Our website, which is endoflifewa.org, is a wonderful resource. We have a lot of documents. They're pretty easy to access. We've just redone our website so that people can find things. There are advanced medical directives to be had. There are assignments of durable powers of attorney for medical decision-making that you can print out and fill out. And those particular documents, you do not have to have notarized or anything else. It just puts you in a position where your desires are going to be carried out the way you want them. So you'll also be able to find material which will either confirm or deny all the things that I tell you today. So there you have it. Let me give you, I'm going to give you just a really short discussion about who we are and how long we've been around. And I'm going to do that by putting up a slideshow. I am not, however, going to do the whole thing as a slideshow because I much appreciate being able to look at everybody's face, see when their heads are going like, is he crazy? Things like that. So I'm going to quickly toss a present now up there. I'm going to go through a couple of slides, chatter away about who we are and where we've been and what we mean, and we'll go from there. So we are now called End of Life Washington. We started way back in the 80s as the Hemlock Society, which was begun by a man whose name has now escaped me, but some of you may know, in England, who they later moved to Oregon. So about 1988, the Hemlock Society started in the state of Washington. And this was long before there was a law or a lot of support for a death with dignity law. We later became Compassion in Dying, supporting people's choices. Then we became End of Life Choices. Then we became Compassion in Choices. Compassion in Choices is a big national organization that helps support death with dignity options in states across the country. And there are now 9 states in the District of Columbia that have a death with dignity option. And about 4 years ago, we broke off from Compassion and Choices because there was a philosophical difference in how we do business. In our state, we are very volunteer-centric, and Compassion and Choices National began to break away from that idea to try to make it a different model. So we are now End of Life Washington. We probably will be for, who knows, another 6 weeks or so. Here's what we're all about. We're about end-of-life counseling and client support. And that means we get probably over 1,000 phone calls every year from people who want to know, does Washington have a law? How old do you have to be? How sick do you have to be? Does your doctor have to participate? And that kind of thing. So we help people with that at the intake level. If it's decided that end-of-life decisions and possibly death with dignity are appropriate, we assign volunteers to go work with those people. And we used to do a lot of it in person. And of course, now in our pandemic, we're doing it much like what we're doing here. We never charge anybody for anything, period. We are all supported by donations. We encourage advanced planning. I just talked to you about that. And of course, a POLST form is that sort of putrid green form that you fill out with your doctor and post on your refrigerator to make it known what, if any, extraordinary steps you want taken to prolong your life. We played a key role, I would say the key role, in the passage of Initiative 1000 in the election of 2008. And we continue to shepherd that law and help people understand the significance of the law 11 years down the road. and we advocate absolutely tirelessly and endlessly for patient-directed end-of-care life, so that as long as they are capable, people get to make their own choices as the end nears. Here is what we've done since it became a law. Now, the blue line is the number of people, not the number of people who have just called our office to ask a question, but the people who actually were assigned a volunteer to work with directly. The first year that the law was in effect in the state of Washington, we had 187 clients that we had contact with. In 2019, we had 697. We'll have more than that this year by a little. Of those, the orange line represents the ones who were brand new that year. The blue line is everyone we had an encounter with during the time. Then the green line is the number of people who used death with dignity law, which has been right around 200 or a little more recently, starting from, I believe we had 37 the first year. And then the number of people who have been our clients and have died naturally is the purple line. So you can see the growth in interest and use of the law. We are, as we said, I'm gonna be cheesy. I'm just gonna read you our vision statement and our mission statement so that you understand a little bit about us. Our vision statement, I feel like these should be dramatic readings a little bit, you know. We envision a world where people understand their end-of-life choices and can die on their own terms without barriers. I believe strongly in that, including for my own self. Our mission, End of Life Washington, upholds your right to a full range of end-of-life choices, including death with dignity, through advocacy, education, and support. And that's what we do. We have a lobbyist in Olympia who watches for possible changes to the law or potential additions or subtractions from the law. And our values, we offer excellent client care, integrity, professionalism, compassion, and stewardship. And I am the embodiment of that whole sentence right there. And as I said earlier, we are always free. We don't charge anybody for anything. We do have a six-figure budget. We have 6 people on our payroll, most of them part-time. We have an executive director and a client services manager who make sure that everybody who needs a volunteer gets a volunteer. And so that's who we are. And we've been around, again, since the 80s. During the period before there was a law, there were a good number of physicians who, when people really were at the end of their life with an awful cancer or some other disease, would find ways to help them hasten their death. All painless, all easy. I actually had a very close friend who had Alzheimer's and also got cancer in the middle of that, and probably as a normal human being would have been able to stand the surgery and the treatment, but as an Alzheimer's patient could not. And the doctor recommended that we basically put them in a palliative sedation, a coma, and then withhold eating and drinking. And so quietly, in no pain and no strain, they passed in 4 days. I hope that doesn't sound barbaric to any of you, but if we get to a certain point, yeah. So that's who we are. Does anybody have any questions about who we are, what we do, why we do it?
I'm just wondering if you could talk a little bit about the idea of how, you know, we can make these decisions if we, like, for example, your friend who who had Alzheimer's? Is that something that has to be done in advance because his or her wishes would not be known after their memory started to fail?
Well, I'll be candid. Alzheimer's and dementia are one of the areas that we are most concerned about, because by the time you are eligible for Washington's death with dignity law and you are within 6 months of your death, you are no longer able to make the decision. You no longer have the cognitive ability. So the decision in this particular case was made by the family. This was a strictly off-label, off-the-books decision.
Right. So is that, I mean, does the law doesn't cover decisions by guardians or family? That's
No.
off the books still.
No. And there's good reasons for that. And I'll tell you one story that it chills me to the bone to this day. I had a husband call to say that his wife was near death and wanted to take advantage of the death with dignity law. So I went out to see him, and in fact, the husband wanted her to take advantage of the death with dignity law, and she had no interest. And he sat with us every minute that I was there, but it was painfully obvious that this was somebody trying to eliminate this person from their life. And we did not end up using the law. I just couldn't. I mean, it would have been unconscionable. In terms of the Alzheimer's and dementia, we have on our site an advanced directive for Alzheimer's and dementia patients. It will not allow you to take advantage of medical aid in dying in any way. However, what it does do is, while you still have all of your cognition and you can make your own decisions, you can write down, when I reach this point in my disease, I want this to happen. And this may be moving me into a memory center, eliminating the home care so that my family can get on with their, and when I get to here, I may want to move to a whole different facility, or anyway, that's the way it's laid out, so that you spell out specifically what steps are taken at what level of your disease. It doesn't have the same impact as the death with dignity law.
So I just want to be sure I have this straight. So if you have a pulse, then if you're in the hospital or whatever, I'm healthy, I'm 73, but I want to, do I need to get death with dignity forms filled out now?
No.
So what
yes.
if I,
okay, here's what the POLST and the advanced directives do. Is those things are to take care of you, take care of your desires while you're still healthy and able to make the decision in the event that you have a major stroke. Maybe you have a glioblastoma and you're no longer able, it's in your brain, you can't think, or you get in a major traffic accident or something like that.
Right.
And you are totally incapacitated. Then
right.
Your desires and wishes for what happens at that point to you are spelled out in the advanced medical directive. And your medical power of attorney has those and can go with you to the hospital or be in the hospital and show these to the medical personnel there and say, this is what she wants to happen. If I am in a persistent vegetative state beyond, and you get to fill out how many days or weeks or years, then I want to be disconnected from feeding and drinking.
Mm-hmm.
That's what an advanced medical directive is. Death with dignity can only begin when you have a physician who tells you that you have a terminal disease and that you have less than 6 months to live. And then you have to take some steps with those doctors to qualify for the law, to visit 2 doctors who confirm your diagnosis and prognosis, to get your medication, and then to decide when you want to hasten your death. So they're 2 separate things. The advanced medical directives and the pulse are what happens if I'm incapacitated. This is what I want done. I want no extraordinary medical.
Okay.
Yeah.
Okay.
Is that clear for everybody? Lots of nodding. I like that.
Okay, thank you.
Death with dignity, in order to use the law, you must be a Washington State resident, and the definition of that is pretty sketchy, and a lot of people have used it here. You must have a terminal diagnosis and a prognosis of less than 6 months to live, confirmed by 2 physicians. You must have the ability to make and communicate an informed decision about taking your lethal medication before you can do it. And you must self-administer life-ending medication. That means, in our case, drinking it or taking it through a straw, or in some cases through a feeding tube and so forth. But you have to do it yourself. This is a quick look at what happens. You originally tell one doctor that you want to use the law. He puts that into your chart. That starts a 15-day waiting period. You talk to that doctor and a secondary doctor who confirm the diagnosis and prognosis. At the end of after you've seen both of them, you must submit a form called the request for medication to end your life in a humane and dignified manner. At the end of the 15-day waiting period, then the doctor can write a prescription for a lethal medication, which you will take, can take, or cannot take, either one. Death with dignity is not for everybody. And I use this just as an example of, I think a lot of it scares a lot of people. But frankly, I think you have to be pretty determined and pretty brave to say, you know what, I'm going to decide when I die, and I'm not going to let the disease decide. But here's the numbers. Basically, in Washington State in 2018, 56,584 people died. 203 of them chose death with dignity, and that is a teeny tiny 0.3%. These are people who obtained their medication and used the medication. Some of those overlaps are because people didn't use them until the following year, and some of them are because they got the medication and never used them. Here are some of the, as you can pretty much figure or opine, cancer is by far the largest cause of people wanting to use the death with dignity law, and the other ones, respiratory diseases, neurodegenerative diseases, ALS, Parkinson's. And then these are the people that we have served over the time since it became a law. 1,007 people have used the law to hasten their deaths. 4,800 people have used an end-of-life Washington volunteer. So that's a big difference. But we help a lot of people along the way, and sometimes they die naturally, and sometimes they use the death with dignity law. Interestingly, we are a very volunteer-heavy state in terms of use of the death with dignity law. 82% of all the people who used the law since 2009 had one of our volunteers at their bedside. The youngest person to use the law with our volunteers is 20, and the oldest was 101. And the primary reason that people use the death with dignity law, rather than simply allowing the disease to take them away, the loss of autonomy, loss of the participation in enjoyable activities, and about half fear that they and their disease are going to be a burden on their family. And that is the last time you're going to have to suffer with any of my slides.
Chris, we just had a question come in from Sheila, which is how much pain happens when I would receive the lethal dose?
There's no pain. There is I will say that, and I tell all my clients this, that try to imagine the worst thing you've ever put in your mouth in your life. And what I'm about to give you is worse. It's terrible. It's sort of like, have anybody ever had the occasion to chew an aspirin or a Xanax or something? It's that terrible, bitter medicine taste, and there's just about nothing we've been able to do about it. So the answer quickly to the pain is absolutely not. The reason you're doing this is to eliminate the pain and eliminate your suffering and hasten your death, and that's that. So yeah, the ugly side of it is the taste of the medication. When I go out, I always ask my clients if they are people who like a little nip. I recommend you take a little shot of scotch. We mix the medication with the scotch, then you take another shot after you're done drinking it, and it gets rid of all of it. Yeah, there's a big thumbs up. But there's a lot of people who don't drink or wouldn't tolerate it very well. And so the thing that I do is I take a little pint of sorbet out, and we give them a little couple of spoonfuls of sorbet, and then they drink as much of it as they can, usually through a straw when it's me. And then we give them another little to get rid of the taste and kind of chill the throat a little bit, and until we can finish it. And you have to take it in 3 minutes or less for it to be really effective.
I chimed in on this conversation because my husband just did the Death with Dignity last month, and I had a fantastic experience with your whole group. He had terminal cancer that we discovered quite late. He was deteriorating very rapidly, causing us both of us all kinds of health problems, losing weight. I couldn't handle him, and it became obvious to both of us that we could not carry on that way and he heard about the Death with Dignity, said, that's what I'm doing. Your end of life volunteer, Caroline, was fantastic. She gave us all the information we needed. She came out and actually gave him the dose, or gave it to him. He was actually waiting. I mean, the 15 days was too long for him to wait. It was very difficult for me to go along with that decision to start off with, because I knew I'd lose him. But as he got worse, I couldn't handle him, and it was either, we had to do something different. It was the perfect solution for us, and of course I miss him, but I'm free, and he's free.
He's free.
Yeah, he's free, and I just have nothing but fantastic words to say for your whole operation. The medicine, on the 15th day, we talked to the second doctor. He had it ordered, and it was delivered to our home on Bainbridge within a couple of hours on the next ferry. I had been told that it might take a couple of days for that medication to get here. By the way, the medication cost about $800,
right?
Which was, it was worth it. And I hate to say that, because some people told me, oh, you're going to kill your husband. No, I'm not. I'm letting him go off to heaven or wherever and be free of his pain. So I got a lot of flack from a few people, especially very religious people. And I just had to tell them it's our decision. Whatever the consequences are with religion, we'll take them. And because we don't know for sure, although we believe. So anyway, I just wanted to chime in my 2 bits here for the fantastic work that your organization did. When we first went to the doctor to get the organization, or to get the process started, my husband is a scientist. And when she asked him, do you believe you have cancer? He said, well, I know, and I have a broken arm. I'm not sure. You tell me I have cancer, and maybe I do, maybe I don't. That disqualified him from that doctor. And she decided that she needed to have him have a psychological examination to see if, and so we waited a week for that psychological examination. which the examiner gave us information at the end of the examination that he was perfectly in control of all of his facilities. He knew what he wanted. I understood what we were doing. And so we had to search for another doctor, and that was the hardest part. End of life gave us one, hospice gave us, it was hospice that gave us one doctor, and we had to kind of search for the other one, but we got it. And just thank you very much for being there and for pushing that law through and for carrying on. I really appreciate all of you. Thank you very much. And that's all I have to say.
Thank you.
If you have any questions, I'll be happy to answer.
Okay. James, you had your hand up?
No, I was just waving and waving my condolences and thank you for sharing that. I really appreciate it.
I will say, and I really do appreciate the feedback, and I'm glad that it went well for you. The people who do this are a pretty dedicated collection, and our group has been very, as I said, our group has been very volunteer centric. There are several states that have recently passed similar laws, but they haven't been able to get their system together. I talked to the lady who runs the organization in Maine, and they try to only find physicians who will not only prescribe, but then go to the bedside. That is, on a big scale, that is very, very difficult to do. And in our state, well, I've been at roughly 100 deaths, and there has only been 2 doctors who have been at about 5 of the deaths. They felt like they wanted to be there for one reason or another. So we do volunteer work. You cannot just wander in off the street and get your volunteer badge and go out and help. You need to, we have an online training, and then we have a 3-part in-person training or in Zoom training as it is today. And then you get a mentor or 2 and you go out with them or you work on Zoom with them to learn the ins and outs. And the best advice I ever got from one of my mentors was, no 2 of these are going to be the same. And it's true. Some of them are very cut and dried. It's a man and his wife, and one of them has cancer, and they want to be very private about it. And you work with them, you make sure they get the medication, you come over, you help them mix it and explain how it gets administered, and then you be there until the death, and then you contact the medical examiner and the funeral home, and you do all the things to try to make it as easy as possible. A lot of our people are not going out for deaths now. They're just doing it by phone or on the computer. And I have not been able to break myself of the habit, because I feel like when I go out, there's 2 clients. And one is the person who is taking the medication, and the other one is any and all people who are sitting at the bedside or in the house at the time. And a lot of work has to go into that. You have to be with them. So again, we train our people. It takes a good solid 6 months, unless you've had some kind of experience as a hospice volunteer or nurse or something like that, before you're ready to go out. And it's not for everybody. It is kind of a burnout thing. You don't realize it, but every time you go out on one of these, somebody dies. It's the end of a life. And there's no easy way to say that. There's no easy way to do it. I still recall I had 3 deaths over a period of 8 days. And at the end of the 3rd death, it was a house that was way out in the woods, had a big long driveway. And I got to the end of that driveway after the death, and I got to the road, and all of a sudden my mind was literally blank. I could not remember, do I turn right or left? Am I going home? Am I going to the store? What am I doing? And I sat at that intersection for, seemed like a long time. It was probably 3 minutes, until my head sort of cleared, and then off I went. And so we're all a little careful about how this goes for us. Some people are more sensitive than others. I am a shrinking violet, little sensitive little flower that, you know, occasionally it gets to me.
Thank you so, so much again. And I just want to thank, and I think it was Pat, I didn't catch the name, but Pat, if I'm getting that correct, thank you so much for sharing about your experience.
Absolutely.
Yeah.
Well, I think it's something that people need to know, that it is, that the organization is there to support you. It's an individual decision, of course, a difficult one for a spouse to deal with, but you have to do it. And I really appreciate you putting this on so that people really understand what's going on and how easy it can be.
Yeah. Well, the one thing I did want to add was that I tell everybody, my clients as well, that making a decision and saying, okay, next Wednesday, I want to die. That's a real hard thing to do. And I struggle with it myself, even if I had terminal cancer or whatever. But I tell them, you know, hospice, I love hospice. Hospice does wonderful things. Their palliative care people can keep you comfortable. And if you can't decide to pull the trigger on this thing, and that's a bad analogy, then there's nothing wrong with going through the process, getting the prescription on file, and then if palliative care is able to keep you comfortable, then just string it out as long as your quality of life works for you.
Well, I just want to say thank you again to everyone for joining us. Chris, thank you so much for sharing all this great information and your experiences. Just very, very powerful. And we're really grateful to have you here. I hope we can invite you back in the future to join us. I think this is such a wonderful topic and just a lot of great information for folks to be aware of.